All right. Well, welcome again. I'm thrilled to see so many people interested in this very important topic. My name is Katie Schubert, and I'm president and CEO of the Society for Women's Health Research, or SWHR, and one of today's co-hosts of today's webinar, along with the Obesity Action Coalition and the STOP Obesity Alliance. And like I was saying, we are thrilled to have you here for today's conversation, Empowering Women Living with Obesity, a review of the insurance landscape, resources, and helpful information. And we're looking forward to discussing ways that women living with obesity can be empowered to take charge of their health, from navigating coverage issues to self-advocacy to advocating for better coverage more broadly. Before we begin, I want to go over just a few quick housekeeping notes. Please note we are recording today's webinar. We will be posting it online and sharing it with everyone who registered when the recording is ready, along with any resources that are mentioned today. To ask a question, please use the Zoom Q&A function. You could use the chat function, but I would really prefer if you would use Q&A so it's all in one spot for me. And we will do our best to get to all of our questions today. Often we have a lot of questions that we're just not able to get totally through. There is a live transcription feature available on this webinar, and you can access that by clicking on CC Live Transcript at the bottom of your screen. And if you don't see it, you might just need to resize your window to be a little bit wider. And for those of you who may be new to SWHR, we are a more than 30-year-old national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And our vision is to make women's health mainstream. As mentioned earlier, we're really thrilled to be co-hosting today's event with our partners, the Obesity Action Coalition, which is dedicated to giving a voice and helping individuals along their journey to better health, and the Stop Obesity Alliance, which is dedicated to reversing the obesity epidemic in the United States. For today's conversation, we're joined by three fantastic panelists. I am going to do a very quick intro and then have them do a little bit of a deeper dive on themselves and what they're working on and sharing their stories as well. We have Michelle Tedder, MSN RN, who is a senior program manager at the Black Women's Health Imperative, where she is the lead on BWHI's current evaluation of their virtual program using their culturally tailored curriculum. And she led the creation of BWHI's Diabetes Self-Management Support Program curriculum, currently being piloted by 3 test sites. And she is going to be sharing her lived experience and journey today with us. We also have Christine Gallagher, who is the Associate Director for Research and Policy for the Stop Obesity Alliance at the Milken Institute School of Public Health at the George Washington University. And her role includes providing the overall direction, leadership, and program management for the Alliance, and also serves as the coordinator for the Obesity Care Advocacy Network. And finally, we have Dr. Tracy Zvenich, the Director of Policy Strategy and Alliances at the Obesity Action Coalition. And in this role, she provides leadership in the development and implementation of policy priorities and strategy for OAC. She also represents the OAC and alliances and coalition efforts to advance obesity care and serves as an adjunct assistant professor at Georgetown University, where she teaches healthcare policy and advocacy to graduate level students. I'd also like to thank Novo Nordisk for their support of this program and note that SWHR maintains independence and editorial control over work products and programming. And so with that, I'm going to ask Michelle to hop on camera, and let's get started with you, Michelle, just in sharing your story and journey with our audience, as well as any other relevant information that you would like to share with us too.
I thank you so much, Catherine, for that nice introduction. I appreciate it. Yes, I am a senior program manager at the Black Women's Health Imperative and also a board member at the Obesity Action Coalition. And it is indeed my pleasure to be here to share a little bit of my story and my advocacy work in this space. So I am someone who has lived with the disease of obesity since childhood. And, growing up, we didn't have access to all of the tools and tips that we have now. As a kid, I just heard, that I was fat. And every time I had a doctor's appointment, the focus was on my weight. And by the time I reached adulthood, I had developed a pretty high weight and ultimately developed type 2 diabetes, had a lot of joint issues, developed sleep apnea, high cholesterol, all of the comorbidities that come along with the disease of obesity. And so, I remember um, going to many doctors, and the conversation was always about you need to lose weight, and that translated into simply that you needed to eat less and exercise more. And I often say in these settings that if I had a quarter for every time a healthcare professional told me that, I'd be very, very wealthy right now, and we would have solved this problem. But I eventually found a healthcare provider, a primary care physician, who specialized in women's health and was very, very, very compassionate and really helped me to understand that obesity is a disease and that it wasn't the result of moral failure on my part, or that it was because I wasn't doing enough, or that somehow I wasn't giving the whole story in her office. And, that insight was so life-changing for me. And I remember the day that she sat me down and she said, Michelle, she said, this isn't your fault. And just hearing that was so empowering. And it really was a game changer. And she went on to explain to me that, this is a multifactorial disease and that I might need a few more tools in my toolbox. Now, mind you, she had been following me for a few years and she had watched me struggle. She had watched me trying all of the things, various weight loss programs. There were many, many, many that I tried. You could name it, and I could probably tell you that I had tried it. And she watched that, and she validated me because I wasn't always as informed as I am today about the nature of this disease, because you hear so many external messages that it's your fault. And then if you just try one more diet, if you just go to one more gym class, if you join one more fitness center, that somehow that's going to change the game. And I was doing those things, but I wasn't getting the results that I needed to improve my health. And so this very lovely, wonderful PCP was able to help me, a nurse. I was a nurse by then, and I still had all of the internal bias that largely was imposed upon me from societal beliefs and implicit bias. And I had developed a lot of internal bias, but she was the person who was able to help me to understand and take a different path. So ultimately, she asked me to consider weight loss surgery. And so after doing a lot of research, talking to a lot of people who had done it, because I wanted to know the good and the bad and the ugly, in 2017, I got the courage to take the leap. And I had the gastric sleeve, and I've lost and kept off about 80 pounds since 2017. But it didn't stop there. And I think it's important that people understand that just because you do one thing that is effective, it does not mean that you won't need additional tools in the toolbox in order to maintain your weight health in the way that you need to maintain it to avoid the comorbidities. And so I have had the privilege of having access to medication. I have access to lifestyle change programs. I have access to nutritionists. And so that has helped me to maintain my success. And I'm happy to say that my type 2 has been in remission since surgery. My joints are feeling a whole lot better, and my sleep apnea has improved. I'm no longer on cholesterol medication. And so I can tell you that having access to comprehensive care for this disease is absolutely a game changer and absolutely necessary. And it should be available to everyone who lives with this disease.
Michelle, thank you so much. And we're definitely going to dig in a little bit more into how healthcare providers and clinicians can be more supportive and some of your experience there. We so appreciate you sharing this story, particularly many of these points made, right? That obesity is a disease, that this isn't your fault, and you need to have access to all of these tools to be able to really continue to live well and really think about your well-being from a comprehensive standpoint. So thank you for that. And we're gonna come back to you in just a minute. I'm gonna ask Christine to come on video and share more information about your role, Christine, and what your priorities are when it comes to obesity.
Thanks, Katie. So the Stop Obesity Alliance has been around for around 15 years, and our main focus has been to look at how to prevent and treat obesity, with a lot of focus over the last decade or so on the treatment of obesity with all the different tools that are out there. So one of the things that we have focused on is how providers need training in order to be able to treat obesity. There are so many providers that that go through medical school or other school programs for PAs and nurse practitioners and so forth, and they don't get that training. And so we've developed some standards for them to be used in medical schools. The other thing that we focused on is we heard from providers that they didn't know how to start the conversation with their patients. So just like Michelle said, many of them didn't actually know how to start the conversation with their patients, so they avoided it. Or when they did, they brought up ideas that really aren't very helpful, like just eat less and exercise more. So we've developed two tools for providers, the Why Wait Guide and the Wait Can't Wait Guide. And then we began to look at coverage issues. So of course, if a provider is able to work with a patient who's ready and willing to take a position on their weight and start to work on treating their obesity, then they need the coverage for that. So we've looked at what coverage is available both in state Medicaid plans, state employee health plans, as well as commercial coverage. And we've done a lot of work on taking what we've learned about what coverage is out there and then developing what we think a standard benefit should be. So we call that the comprehensive obesity benefit. And I will go anywhere and share that with anyone who has the power to be able to offer that to their patients and to their beneficiaries. And one good example of that is that we worked closely over the last 3 years with the Office of Personnel Management here in Washington, D.C. They are the largest employer because it's the federal government. So they're the largest employer in the United States. And we worked with them to help develop their guidance to their health plans called the Federal Employee Health Plans on what they should be including for comprehensive obesity benefit. So they are the best example that we have right now of what's out there. So I'll stop there and happy to engage more when we get into conversation about some of the other ways that folks who want to advocate on getting better coverage can do.
Excellent. And we will definitely get back to that. I see a really great question in the Q&A that we're going to get to here in just a few minutes. I'd like to invite Tracy to turn on her camera and please go ahead and, oh, you're a little bit blurry, Tracy. There you are. Okay. Thank you. Go ahead and introduce yourself and tell us what you're working on and priorities are and messages to the audience.
Yeah, thank you so much for the opportunity to join you all today. So the Obesity Action Coalition, we've been around for almost 20 years. We'll have our 20th anniversary next year. And we are so lucky to have such a strong member of our board with Michelle Tedder joined here with us today. So OAC, we are the patient advocacy organization, and we are dedicated to serving people living with obesity. And we do this in kind of in three main ways. We do it through providing support to people living with obesity. We do it through providing a whole range of education topics and resources. And then thirdly, we do it through advocacy. In our advocacy work, we focus in areas around one, access to care, And second, around ways to reduce and eliminate weight bias and weight-based discrimination. We do our advocacy both at the federal level as well as state level. And then we do a lot of work around ways that we can change the narrative around how we talk about obesity, how we talk about people living with obesity. Katie, you already mentioned that, better education and understanding around obesity as a chronic disease that deserves access to care. People living with the disease of obesity should have the tools and options that Michelle spoke of available when it comes time for them to seek care on their journey. So OAC, we are here again to support, educate, and advocate for the whole population living with obesity. We have over 85,000 members. Our membership is comprised of people living with the disease of obesity, providers that care for people living with obesity, as well as family members and caregivers as well. So really excited to have this discussion today, and look forward to the questions.
Great. Thank you, Tracy. Christine and Michelle, please feel free to come back on camera. I see some really great questions coming in here. I actually want to start with a couple of things and start with something that you were getting to, Tracy, I think here right at the end, which is how do we shift this narrative and this conversation and how do we tackle bias and stigma when it comes to obesity, as well as I think when we think about women in particular, this conversation that this is about vanity. And again, going back to, like this is your fault and you're just not doing enough to be able to address it. How do we start? And then of course, Michelle and Christine, feel free to jump in as well.
Yeah, it's such a great topic and a great question. And that deserves more awareness and more discussion of understanding about what it actually is we're talking about. So really quickly, I think it'd be helpful to say, just to lay the foundation that weight bias is really carrying negative perceptions, attitudes, or beliefs around people living with obesity or people in larger body sizes. And then the weight stigma is more like how those things are expressed or how those things, demonstrate themselves in the world or in the life of someone living with obesity. So, that can take multiple forms. So what that can look like, Michelle already mentioned implicit weight bias, where that's kind of unintentional or kind of unconscious ways of showing bias. And then there's explicit weight bias, where that's like intentional, someone very consciously is saying something or taking an action. And it can happen in a variety of settings. So it can happen publicly, it can happen through relationships, it can happen internally, a lot of shame and blame around our community of people living with obesity, and statistically, it's quite common. So understanding that this is a common thing. Once you have awareness to weight bias and you understand what it is, it's kind of one of those things that you can't unsee. You see it everywhere then. So there 40 to 45% of people self-report experiencing weight-based discrimination, weight bias and stigma. It's weight bias and stigma is the second most common form of discrimination for women. The second most common form after gender. It's the third most common form of discrimination for men behind race and age. So it's very common, very common. 3 times higher in people with obesity versus normal weight, and 2 times higher for women versus men. So the prevalence of receiving weight bias and experiencing stigma grows with your severity of obesity. So the larger the body size you have, the more weight bias and stigma that you face. So there's actually there are implications of weight stigma and weight bias as well. So you're living with obesity, you're experiencing weight bias and stigma. This has documented in research and evidence physiologic and psychological consequences. That has implications then that lead into your life, whether that's work, school, social settings, and that perpetuates more bias and also internalizing that. So it's almost a cycle that that occurs and perpetuates because weight bias and stigma is just so common and prevalent in society.
My gosh, I appreciate you putting that in perspective too, because I think when you hear all of that all together, I think you're really able to think about the framing of this issue, and it is not just a one-off or one clinician or one experience. It is really sort of pulling these things together. When we think about women as well, that intersectionality piece, the different identities that women take on and roles that they take on too, I think it just compounds a lot of that, the bias and the stigma as well. Related to that, Michelle, I wanted to ask you to talk a little bit about what you found to be most successful when you're working with healthcare providers in advocating for yourself.
Yeah. Well, first off, I would say that you have to find a healthcare provider who gets you, right? Who really understands that you are more than your BMI, as I say. You're so much more than that. And that every problem that you come to the doctor's office with when you're overweight or, living with obesity, it it's not about your weight necessarily. So I think that for me, um, finding that right physician who was able to, one, educate me. And I can certainly echo as a nurse that in my training, we didn't talk about this in school. We didn't get training around how to work with people living with the disease of obesity. We got a lot of information about other comorbidities that happen as a result, but we did not get it even in the context that was related. So, I would say that being well prepared with information and clearly communicating your symptoms, your concerns, that has been crucial for me. And I've found that asking a lot of questions and then not hesitating to seek a second opinion. I have fired several physicians because if I don't feel that you see me, you get me, that you're validating me, then that's not good care. And as a health professional, I count it as a responsibility to give people compassionate, validating, highly individualized care. And I will not accept anything else on the other side. I feel like I'm a unicorn, so I can sit on both sides of the fence as a patient living with this, but also being a very well-trained healthcare provider. And so I would say to anyone who is seeking care, if you walk into an office and people are not treating you correctly, that it's all about your weight, or they're dismissive, or they're telling you things like, oh, come back when you lose 50 pounds. Like I had a physician tell me that. I had a knee injury and I had a physician, after seeing multiple orthopedic docs, and one said to me, well, lose 50 pounds and come back and see me in a month and we'll talk about your knee. That's irresponsible. It's irresponsible, it's discriminatory and not acceptable. So I would say that for me, in terms of being a healthcare professional, but then being on the other side, is really demanding that you have appropriate care, no matter what the situation is, that you have a right to that. You deserve that.
Absolutely. Thank you so much for that. I think a couple of threads to pull onto for folks, and then I have a question for Christy I want to get to. But really this idea that if you're not being listened to and heard about what really your health concerns are, then yes, 100% you seek another opinion, because you want someone who's going to engage in shared decision making with you, and nobody knows yourself more than yourself, right? So, and really feeling empowered in that, I think is really critical as you enter that. And there's been lots of stories as of late, but these have existed for so long, about things like medical gaslighting and being told this is all in your head, and there's nothing really wrong with you. And in this case, I would imagine, there's nothing wrong with you except you need to lose weight. And that's just not an acceptable answer when we think about actual access to care and treatment options. And so on that note, Christy, maybe you could talk a little bit about the different treatment options that do exist for women living with obesity. And I know you mentioned a lot of really great resources as well.
Great. Thanks, Katie. Just a couple things on the bias and stigma too. Also, So one of the things that you'll hear us using the language today, and that Tracy also pointed out, is, you know, when we as both educators and those in academia, as well as advocates, and anyone sort of working with you know, providers or communications even, it's really important to use people first language. So we use the, you know, words people living with obesity, people living in a larger body. We steer clear of using the word obese. And one of the things in particular, if you're like working with like putting out a report or working with the media or doing any type of social media, it's really important to use pictures of people, you know, real people living with the disease of obesity. You know, we don't want to use those butts and guts pictures that are so commonly used with the newspaper or when a story goes up on online about the disease of obesity, or sort of, and there's so many stories right now with everything going on with you know, these new medications. So that's really important. And the other thing was that studies have shown that if people are shamed about their obesity, if they're told, you know, in any type of sort of external bias that, you know, Tracy was mentioning, that actually will lead people to gain more weight rather than lose weight. It does not help to shame people into their obesity, to thinking that they're going to magically go and, you know, lose a bunch of weight. So just two other points. So yeah, so there are several components to our comprehensive obesity benefit that I mentioned earlier, and it's kind of a continuum of care. So when you think about, you know, you know, everyone should be actually screened by their primary care physician on an annual basis, and those that are given a diagnosis of obesity should be offered treatment and sort of the lifestyle intervention type programs. So that would be anything from nutrition therapy to physical exercise, and however that, you know, physical activity needs to be met, as well as what we call intensive behavioral therapy, which is, you know, working with someone again on what your goals are, and any type of mental health challenges or other issues that might be preventing you from getting to a healthy weight. But many people are successful in that. Programs have shown that people can lose up to 5% of their body weight, and losing 5% of your body weight can actually do wonders to some of those other comorbidities and decreasing joint pain, helping with sleep, and other factors. But as we know, there's lots of other tools out there. And so if you continue going down the continuum of care, we have these new what we call obesity medications. Some people call them anti-obesity medications, but there's actually several of them, and they've been on the market for a while. So the buzz right now is all around these new GLP-1s, and those are the new medications called Wegovy and Zepbound. But there are several others that have been around since around 2012, 2013, including one called Contrave, and then one that's been around for quite a long time that is actually one of the most commonly used medications. It's a pill called phentermine. It's supposed to be used mostly for short term for weight loss. So doctors do have tools. They have tools, and they should be looking at that, because not every medication, not every treatment is going to work for the same body, and often it should be a combination. So we advocate that any medication should be used in combination with intensive lifestyle therapy as well. And then for those people who have a BMI of 35 and above with comorbidities, or 40 and above, they are actually great candidates for surgery. So there are a couple different surgical procedures right now for metabolic and bariatric surgery, and those should also be covered for any type of revision that might need to happen. So often people have surgery, it works for a while, but then they need to have a revision to that surgery. In our plan, it should be covered for that. And then we also talk about weight maintenance. So it's just one thing that hasn't been talked about a lot, but it's important to know people are going, especially with these powerful new medications, people are going to reach their goal weight and their healthy weight, and they're going to feel comfortable where they are, but they're going to need support in order to maintain that weight. So there's a lot of different studies looking at, you know, do you stay on the GLP-1s? Do you move to a different type of medication? Do you go off of them and see if lifestyle intervention programs will continue to help? So we're still trying to figure that out. But right now, our what we advocate for is that all of those should be provided and they should be covered by health insurance for people, because they're going to need support. This is a lifelong disease. It can be relapsing, and we should think about it like we think about anything else. High blood pressure, high cholesterol, heart disease. It's one of those that needs to be treated just the same as those. And then what we're seeing in the research is fascinating right now, right? Like we're finding that people that are being treated with these brand new obesity medications, their type 2 diabetes never develops, or they begin to have the joint pain that they were living with. It goes away. Sleep apnea goes away. They're able to lose the weight and eventually have some of those surgeries that they've been putting off, or even some of those prevention activities. So, you know, several people don't want to go to the doctor, don't want to go get the prevention things. They don't want to go get their pap smears or their colonoscopies. And so it just kind of goes, it's like uncovering the box, right? Once you deal with one issue, then there's several other under there. And so we want to be supportive to people that are ready to work on their obesity, and then also make sure that there's supports there for them once they reach those goals.
No, that's great. Thank you so much. I think that also leads into another question, which I'd love for everyone to jump in with your advice and thoughts here. A really great question about how obviously there is sort of a patchwork, and we see this in a variety of ways when it comes to coverage for treatments and services across the board. We are seeing it quite prominently in this space as well. And so the question really gets to, how do folks advocate for insurance companies to identify obesity as a disease so that it's easier to get coverage for this comprehensive treatment? And I think sort of a couple of different parts there. It is recognized as a disease. I think there's a challenge related to coverage in a variety of ways, but would toss that question out there for each of you. And Christy, if you want to maybe go first, you're off mute already.
Sure. So when we developed our comprehensive obesity benefit, we actually put together a checklist, and it's on our website. And on the checklist will actually help you go through your own health plan so that you can see what you currently have as coverage. Just be aware that it's not going to all be in one place. It's a comprehensive benefit, and it's kind of all over the place. So you need to search terms like obesity, weight, obese, weight loss, diet, nutrition, and try and figure out where these different coverages are in your health plan. And then if they're not there, I think there are different ways that you can advocate for that coverage. If it's a state public plan or a federal public plan, there's definitely ways that we can use your help in advocating for that. But maybe Tracy wants to touch on some of the ways that OAC has done advocacy work on increasing better commercial insurance as well.
Yeah, I mean, Christy's kind of just speaking to kind of the higher level policy issues that we run into from an access and coverage perspective. So there are some kind of baseline policy barriers that we're trying to address. For example, in Medicare policy. Medicare policy around obesity care has gaps. There are gaps for actually all of the types of evidence-based interventions that Christy just overviewed. There are ways to improve those from a Medicare policy perspective. And Medicare is one of our priority policy areas because it has a ripple effect across other payer types, both public and private. So when Medicare makes a change, oftentimes other payers will make a change. So that's one of our priority areas, to improve access to obesity care in Medicare. We're also working closely on improving access to care in Medicaid across all of the states. And then state employee plans, given that they're oftentimes the largest employer in any given state. We work with state employee plans. So really trying to see, like, work with the payers that have large populations, have large numbers of beneficiaries. Christy also mentioned the federal employees, which is millions of people as well. So we advocate for better and improved access to care for evidence-based obesity treatments with any payer. We also, sometimes see specific policies pop up in commercial plans that we'll dig into and try to address and try to, help people navigate or better understand. Transparency around what your health plan actually covers is a big issue as well. So data is improving in some areas around understanding what policies actually say for coverage of obesity treatments, but I'd say transparency is also another area around this category of care that we have a lot of work to do and a long way to go there. But there are resources, there are groups like ours that are here for people to help, and we're always happy to have those conversations and get people involved when they want to be a part of, want to use their voice in their story to elevate our efforts as well.
That's wonderful. And yes, we will be sharing resources mentioned as well in our email to folks with the recording. And there were a couple of things. That transparency piece is so interesting, Tracy, because I have heard stories from folks who, their clinician will look to see, oh, let's just see if this is covered. It looks like it is. They prescribe it. And then they get to the pharmacy and they're like, no, this isn't covered. It's an exception to coverage. And so I do think that is particularly challenging as well, just in thinking about and fully understanding, what is included in your plan. And so, and to your point about Medicare, of course, maybe setting the stage, right, and allowing for opening up for some of these folks who don't currently have coverage. That's really important. And obviously we all here are following the Treat and Reduce Obesity Act, which we're watching hopefully make its way through Congress, and then obviously working directly with CMS as well to make sure that there's coverage and access available there too. Michelle, was there anything you wanted to add just in terms of advocating with your insurance company?
Yeah, I would say that it's important to, with my advocacy hat, is to be informed, as my friends here have been saying, but you need to really be informed about what your plan is, and don't be afraid to use your voice. I think one of the things that I wish I had known sooner was the power of understanding how critical it is to know the connection between policy and access to care. And I think that a lot of patients don't connect those dots. I don't think the average person does, right? It's like, you get a job, you want the health insurance plan, then you get it and you go to get care, and it's like, wait, that's not covered, that's not covered, that's not covered. Oh yeah. Oh, by the way, you live with obesity. Oh, we don't do that. So I mean, really understanding the connection between how those things come to be and why you do or do not have access is critical in knowing like what to advocate for and how to advocate. And I really, push people from an advocate standpoint to understand that, and don't be afraid to learn to be an advocate, first for yourself, but then also for like your communities. The Black Women's Health Imperative, we're the oldest organization that is solely focused on the health and wellness of Black women and girls. And so I work on the policy side around obesity, and really am encouraging people to understand why you don't have coverage, even if it's medication. I mean, everybody is not going to be a candidate for surgery. Everybody may not be a candidate for medication, but if we can advocate that everybody has access to all of the tools if they need them, because there's not one size that fits all in this, I think there's more power in that. So really, really understanding that policy drives everything. It drives everything. I don't care what it is that you're talking about, and especially navigating the American health system. You need to understand policy and how it's impacting you.
Yeah, I mean, that's such a good point, particularly as you think about what it's meant for when you think about insurance coverage. And I say this a lot, and I'm gonna take the opportunity to say it again, which is that, you know, the system is created to make sure that costs are reduced and that, you know, there's no fraud in the system. It wasn't necessarily created to look at health outcomes and well-being. And so we're sort of in some ways trying to fit a square peg in a round hole in a lot of these issues as we think about focusing on access to care and treatment and prevention, and really this comprehensive approach to well-being, fitting it into this system that wasn't necessarily created for that. So I think that's a really important point, is to really understand that intersection. I don't know if Christy or Tracy wanted to add anything here. Okay, so there is a couple of interesting questions here. One is related to whether anyone has insight on how much emphasis is being put on therapy to understanding any underlying issues that may come surrounding binge eating or whatever might promote obesity and comorbidities. I don't know if you all wanted to jump in and share some insight there.
Well, I think all of us here on the panel would say that this is a total, like a 360 kind of approach, and that having access to lifestyle change programs, having access to behavioral health therapists, having access to medical professionals who are well trained in how to navigate and how to put together a collaborative treatment plan for you, right? All of those things are very, very important. And I feel like if you leave off one of them, because sometimes what I'm in rooms where people are like, oh, well, if we pay for X, Y, and Z, we will have to pay for the other. And it's like, no, that's not how this works. Like, I'm the poster child for like having access to everything, like literally therapist, you know, nutritionist, the medication, all of those kind of things. And I know that my ability to maintain the level of health that I've been able to achieve as a result of having access to those things makes a difference. Like, it terrifies me to think about becoming 65 and then they're like, oh yeah, by the way, you can't have coverage for that because Medicare doesn't pay for it, you know? So I think looking at these things from, I mean, you can't look at it in a vacuum. You have to look at the sum total of everything, because the treatment plan that is working for me may not be the same one that might work for Tracy or for Christy or for Jane or for Joe or whatever the case may be. So that's why we have to really, really elevate our voices to say, no, we need to come up with a plan that whatever it is that people need to have optimal health, that's what they need to have. And it's, you can't prescribe it one size fits all. It doesn't work that way.
Christy?
I would add that, yeah, I would just add that the best case scenario is that you are able to find a center that addresses both your, you know, your healthcare needs, your nutritional needs, physical activity needs, and then your mental health needs. And so there are a lot of cases where, you know, binge eating, even, you know, other sort of healthcare issues with mental health that impact your weight and impact obesity. And the best people to address that are mental health professionals. And the best places that you can go to address obesity would be sort of a well-rounded sort of center like that. You know, back when bariatric surgery was beginning to be covered, they called those centers of excellence, and they had, you know, just a whole team of providers that were able to help people get prepared for their surgery, have their surgery, and then recover from their surgery. And so that's the type, you know, if you have access to that, that's definitely the type of place that I think would be helpful. But, you know, we know not everybody has access to that. So I do think that finding a mental health professional that can help you and tie that into perhaps some of your eating patterns is a really good way to go about that.
Yeah, and I would just add, I think this highlights the importance of having trained and qualified healthcare providers, where in the process of a comprehensive assessment, they will be able to screen for and evaluate whether, whether or not there are disordered eating, disordered eating uh, at play here, or a mental, other mental health issue at play, and get people the care that they need, right? So, I mean, disordered eating and obesity can coexist, right? So you have a trained and qualified healthcare provider will know how to help that person, right? But it is really important that our healthcare providers are educated and can help people in that way too.
Yeah, thank you for that. There's a question here I want to ask, and it goes back to some of the provider clinician side of things, which and I think they're expressing frustration, which I totally understand, and it looks like it's coming from a primary care provider. So, any thoughts on? And I think I think I know where the answers to these are going to go, but I'm going to ask it. Any thoughts on not addressing weight and weight management because they're trained to ask, when do you want to talk about your weight? And then being dinged sort of on the back end for not addressing it because it's not something that the patient wants. I wonder about your thoughts on this and better ways to potentially have this conversation, maybe so that it's less weight centric and more about health centricity and sort of the needs of the patient, but wondering sort of what the current thinking is on that, so that I understand. I think this primary care physician or provider in particular is frustrated that like they want to address it, but they're not able to because maybe the conversation isn't going in the direction that maybe it could be.
I think I'm going to put both hats on. First, I'm going to put on the patient hat. I think for me, it's about coming to me in a compassionate, curious tone, right? Because there's many providers who don't. And I experience them. It's kind of like, well, have you thought about your weight? No, I didn't think about that. I mean, come on, of course, of course. Most people who live with this and have lived with this for a long time, let me tell you, it's at the forefront of your mind for everything, right? So it's not a shock, but it really has to do with what is your approach and how you're coming, and are you willing to have a compassionate conversation that starts out like, hey, would it be okay if we talked about your weight? Do you want to talk about it? And just give people the option. If they say no, maybe they don't want to talk about it right then, but if you build the relationship, they might want to talk about it in visit 2 or visit 3 or visit 4, whatever it is that they initially presented to you with. My former primary care physician, she watched me like for 2 years, and she would say to me, she says, you might want to think about X, Y, and Z. And I'm like, I'm going to do this on my own, because I was still running on the fumes of the implicit bias. Like, Michelle, you're a nurse. You ought to be able to do this. Like, you need to exercise more. I bought into the craziness, but she was able to say, hey, wait a minute, let's talk about this. And she acknowledged, she said, Michelle, I've watched you. And she believed. So what that signaled to me was, oh, she believes me. She believes that I really am trying to do all these things. I was starting programs in my community. Everybody else was losing weight, not me. Seriously, facts. Those are facts. And so I think what I would say to the healthcare providers on this webinar is that there's a way to approach patients that makes them feel safe. You've got to create a safe environment for people to be able to talk about it. So if maybe they've come to you and you're treating them because they've got asthma, and that maybe losing a little weight might be helpful. You might not hit them with that the first visit, but it's like maybe you provide it in the context of a lot of other information. Hey, research says that, if we look at these things and these things, that this might help this condition. Are you willing to talk about that? Are you interested in talking about that? So I think it's really all about what you come to the table with and the spirit in which you bring it.
Yep. I love that.
Yeah, I was thinking the exact word of compassion, and I would just also add, respectfully and the seriousness of it. because, you know, in just framing, I like the way you framed it in that, you know, obesity is a discussion around obesity or weight management is just a part of the whole health discussion, right? Like framing it in that way and giving it the same level of seriousness as if you're talking about someone's diabetes management or someone's cancer care.
Mhm.
Yeah.
I think so many times providers consciously and subconsciously come to the table with almost an accusatory tone that somehow you're not doing something right. Somehow, you know, you failed in some way. And I think that that just makes you close up and you're not going to feel comfortable enough to even talk about the things that you've probably been rolling around in your head for years, and really want someone to create the safe space for you to talk about how hard this is and how frustrated you are as the person living with the disease, and that you just want a safe person to be able to talk about it with. Most people want to be able to talk about it, I believe, but there's not safety in talking about it, even with healthcare professionals.
Yeah.
So we put together a guide called the Weight Can't Wait Guide, which, you know, I think would be helpful for some providers to look at. But I do think a lot of patients feel like they've been to their doctor so many times and they've never been able to offer them any tools. And so if you are a provider and you are going to uh, offer that or ask that question, do you want to talk about your weight? Is this a good time to talk about your weight? If not, you know, I'm here, make a follow-up appointment. You know, those are the sort of tools that we give in our Weight Can't Wait guide. But you have to be able to follow that up with the tools. You know, the patient's going to want to know, like, well, sure, I'd like to talk about my weight. This is a safe space. But, you know, if you're just going to tell me that I need to, you know, walk more after dinner, that's not what I want to hear. I've tried all of that. I've tried it over and over and over again, and you need to meet me where I am, and you need to be able to provide me with some options that are going to work. So
I think to that end, Christy, that emphasizes the importance of educating yourself, right, as a healthcare provider around these issues. Because I think, you know, my primary care physician, she was a specialist in women's health. She also understood the disease of obesity. So she'd taken those extra steps to educate herself. And she absolutely had a solution. And I felt safe with her. I trusted her. Okay. And I'm going to say that again. I trusted her. So when she said, Michelle, please, I'm asking you, begging you, these are her words. Would you please talk to my colleague who happened to be an obesity surgeon? And so because I trusted her, I was like, okay, I'll go talk to her. I'll go and I'll get the information. So you're really the gateway, because your primary care physician is probably the person that you see the most often. That's the person you're going to go to when you have a headache, a earache, a chest, whatever it is. And so you actually have the power to build a trusting relationship if you're concerned about the overall health, and really talking about it from that standpoint and wrapping it in a package that is digestible, no pun intended, but then you can bring in that conversation as a caring provider who is someone who is respected in your patient's life and you're trusted by them. So you've got a lot more power then than what you think you do, because you've got the trust, if you've got the compassion, and you have the ability to put that thing together in a package that says, listen, I care about your overall health, and I'm not just singling out your weight as a reason for me to talk to you about this, but I'm concerned about all of you. I'm concerned about everything that may be impacting why you're here.
Yeah. I think these are really excellent points, and we have just a couple of minutes left, if you can believe it. So first of all, thank you for that. I want to ask one last question, and I want to also just point out quickly, there's a couple of points here about thinking about this issue from the perspective of pregnancy, and then one about whether there were recommendations at different times or life stages, particularly for women like menopause. And I think that's a really interesting observation and something that we probably need more research and conversation surrounding, but it gets back to the need for this comprehensive care and coverage so that each individual has access to what they need and what might work best for them. But I think at the end of the day, when it comes to life stages, there's a lot we still don't know when it comes to women's health and the intersection of research there. So I really appreciate the question, though. I did not plant it, but it was a really great question. But my last question for you all is back to some of the policy issues. What do you wish lawmakers knew about obesity?
I would say first and foremost that it is a disease, that it's a disease like everything else. And so just like they've gone hard for policies to make sure that, people have access to treatment for heart disease or blood pressure, or, women have the right prenatal and postnatal care, that they would understand that the disease of obesity is just that, and that we need their voice and their commitment to opening the doors to make sure that we have comprehensive access to tools.
Great.
I would say it's interesting. The last couple of years have been much easier to talking to lawmakers because they are beginning to understand the disease. And part of that is, all the news coverage about these new tools, these new medications that are out there. But I would say it's important that they also understand that not everyone is going to rush to get treated. I think a lot of lawmakers think, oh, if we open the door and make it possible, like if we cover Medicare, if we cover Medicaid, if we make other changes to make it easier for people to access treatment, that everybody's going to rush to the door. And that's really not what we're seeing. That's not what's happening. And again, we've talked about all this entire hour about many of the reasons why providers don't know how to train, aren't trained. They don't know how to treat. They don't treat. They're not compassionate, and patients don't feel comfortable going to their providers. So it's not going to be this rush of people going and signing up. And that what we really need to focus on are the people who are living with the disease, who are ready to be treated and want to be treated and should have that access to care. We're not talking about people who can fit into, a bathing suit or a wedding dress in a few months. That's not the people that we're talking about that should have access to care.
Thanks for that, Tracy.
And I would just wrap up with, I think I am going to be so excited when I see lawmakers saying this is something we need to invest in. We need to invest in people's health in obesity care, and it will improve the overall health of our nation. So, with obesity being the root cause and the driver for so many health complications. And I just look forward to that day when they stand up and say, yes, we're going to invest in this.
Love it. I love that message. Thank you all. That hour flew by. We so appreciate each of you taking the time to share your expertise and your experience and your insights with us. Thank you, audience members. You all stuck around, which I think is so important when we think about continuing this conversation. So we, again, really appreciate your time. Please stay connected with us. You can see all of our channels, stay connected with the folks here. We will, like I said, share resources and the recording with you all. And again, thank you and have a great day, everyone.